Okay.
Sorry.
No problem. So alcohol. So to continue our substance abuse disorder talks, we've been working on what we do with patients that have alcohol substance abuse disorder. And for a long time, the hospital has treated alcohol abuse. They had a program which would allow patients to be admitted to the hospital for detox. And so basically all patients that came in said, if I want detox, and they'd get admitted to the hospital, which is different than most other hospitals, right? That's kind of rare. And so we were just trying to look at what that process is and why, and do all patients need to be admitted to the hospital? And is it best for all patients to either come to the hospital or not? And that was sort of the question. And sort of looking at up to date and talking to other people, what a lot of people do is you can try to find groups of people that need hospital detox and groups of people that would the outpatient treatment would be adequate or even better. And so that's sort of what we did with this first algorithm, which helps to differentiate inpatient versus outpatient treatment. And then from that point, if we're going to have more outpatient treatment, what is that going to look like? Who are they going to follow up with? Because as we know, alcoholism, chronic, recurring, remitting illness, a day or two at MDI hospital is not curing anything, right? So really connecting patients to the outpatient world for their continued treatment. So kind of similar to the previous algorithm that we looked at, basically a full workup, including labs, and then a CWA protocol, which another issue with the process that was currently being done is that the inpatient nurses were using a different scale than CWA.
Yeah.
So we would do a CWA in the ER and be like, CWA is 8, and that number would go upstairs as 8, and they would do a score, but it wasn't a CWA score, the number was 4. And so you're like, okay, he was an 8, now he's a 4, but what does that mean? Because they're completely two different scales. And then what happened, we had all new hospitalists come in, and they were used to CWA scores, and so they were thinking, okay, this person's a 4, I know what a 4 CWA score is, but no, it wasn't, it was apples to oranges. So what we tried to do is get something that was hospital-wide CWA based. So that everyone's talking the same. So if I say an 8, you know what an 8 means. It's the same 8 as the nurse on the floor, same 8, just kind of makes sense. So that was sort of the impetus for why this is here, sort of to figure out which patients can we be treating outpatient and to have one standard CWA score. So basically, if the patients are sick, we admit them. Right? So someone comes in and they're like, hey, I really want detox. And then you're talking to them, and they haven't eaten in a week, and they've been vomiting, diarrhea, and their sodium's 115. Right, sodium's 115 or something. So that's simple, right? You're not admitting for detox anymore. Now you're admitting for sick, electrolytes, something else, right? So a simple detox is, I want to stop drinking, and I'm perfectly fine other than that. Everything else is good. So kind of bounce past that. So they're not sick, so you don't have to admit them for being sick. The next question is, what's their CWA score? So after initial treatment. So they come in, we give them a dose of Librium, and we check their CWA score. It's 16, which is pretty high. We give them a dose, either a dose of Valium IV or a dose of Librium. Watch, see how they do. Okay, now they're feeling a little better. They're down to a 10. Okay, so if they went up to like a 20, things are getting worse. Then now we're not talking about detox. We're talking about withdrawal, right? They're in high enough withdrawal that they need to be admitted for withdrawal so they don't seize. So just to make the distinction, so detox are those patients that they're not sick, they are not actively withdrawing, they want to stop using alcohol. And those are the patients that this first page is for. Alcohol withdrawal is, I haven't had a drink or benzos in 6, 12, 24 hours, and now I'm at a CWA score, that's high, and I'm a medical emergency. That's the second page, which we'll get to, that how to take care of patients that are actively withdrawing. This first page is, what do we do with patients that are requesting detox? Okay. So first we can identify patients, right? Just like the SBIRT we talked about with opioids. Oh, you're here with cellulitis. How much do you drink a day? Wow, you drink a liter of vodka. Okay. And then you can have your intervention. Oh, are you interested in changing? Tell me about it. And if they are, then you can have that conversation about either inpatient or outpatient. So we can identify patients that have alcohol problems too and get them into this detox algorithm as well. But basically, if you keep going down the algorithm, say the patient has a CWA score of 10 after a week treated. So they're not withdrawing, they're not significantly withdrawing, they're not sick, and so next question, are you suicidal? If they are, then we're going to be talking about Acadia and crisis and all those other things, not a admission for detox. So let's say they're not suicidal. The next question is, are they interested in detox? Okay, I can say, nope, I'm not. I have no interest in doing this. So, okay, then you can discharge home, insure for safety, you can provide phone numbers. The next question, does the patient have contraindications to outpatient detox? Now you're trying, so say the patient's interested in detox. So now we're trying to determine, can they be safely discharged for outpatient treatment, or do they need to be admitted for inpatient treatment? And the bottom left has your contraindications. We basically want to pick safe patients to discharge for detox. So if somebody has some, psychosis, suicidal, homicidal, they have a history of withdrawal, of seizures, they have horrible medical problems, they're also using benzos, those are some of the contraindications. That's probably not a good person to give Librium to and say follow up with your primary care doctor. Those patients would be you'd be discussing with the hospitalist. And so for all detox admissions, the hospitalist has say. They get the say on it, because it's not a medical emergency, it's not a medical admission, it's more of a social, we're trying to help people out, to help try to get them to get off of alcohol. But
is that part of the problem, is that we do consider it a social pain instead of a medical pain?
Well,
I'm talking
two different things, detox and withdrawal.
I'm talking detox.
Yeah.
So detox is a medical. It's not a medical emergency. Detox. It's a optional,
Right.
elective.
Right.
It's an elective thing, right? Detoxing
Okay,
alcohol
so
is
like
elective.
if you were having an elective surgery.
Yeah.
Mhm.
I would look at it as an elective thing that
You're
you
probably
can
not gonna give up
decide.
the
You
last-
can come back during business hours.
You can decide to drink alcohol, or you can decide to stop drinking, right? It's an elective thing, which, as opposed to withdrawal, is
Is a
you
medical
actively have a
emergency, yeah.
medical emergency going on currently. That's how I look at it. I mean, I don't
But
know.
if you're addicted, you don't really have a choice whether you drink or not.
What about
I
the
mean,
patient
you
who's,
put it to your lips or you don't, but
Yeah,
it's,
but
you need it.
withdrawal will kill you, detoxing won't,
Mhm.
until you get to the withdrawal
Mhm.
state.
Until you get to withdrawal.
what about our patient that comes back with frequency? Like there was twice in a week or
Yeah.
something?
Yep, and this is sort of a
Expectation.
this is a general guideline, but the hospitalist has,
They get to decide.
they have final decision, because we can just, someone has to have the final decision, and we
Mhm.
just determined that the hospitalists, they're the ones that are gonna take care of patients for days, so they get the final decision. We can advocate for our patients if we feel as though they would be a good candidate for inpatient. But some patients can be difficult. Some patients might have what we talked about earlier, personality disorders and.
Well, and probably a great percentage do.
Yeah, right. So it can be difficult, and so they can be hard for the hospitalists and hard for other people to take care of, and yeah.
And maybe they need to be in both programs.
Yeah. So, say somebody is determined to be okay for outpatient treatment. So it gets back to that. This is where we have a lot of work to do to try. This is our opportunity to get patients to the care they need. So try and establish care with open door. So I'm going to pass these around. So right now we've got the hub for opioid substance abuse. We're trying to find a hub for alcohol, right? Because the hub doesn't work with alcohol. It doesn't work with alcohol with patients that are abusing alcohol. So we've spoken to Open Door, and they are kind of arms open. They said that if you call us at 4 o'clock on a Monday, we'll stay till 6:30. they want to be available and open and ready. You know, they're not 24/7, but they want to see patients same day, if not next day. So that's sort of the closest thing that we have to a hub for patients with that are having issues with alcohol. So we can ask the patient. The thing with Open Door, it's intensive outpatient treatment. It's kind of the same thing. You know, they're there several days a week for several hours. It's in Ellsworth. Kind of the same issues with the hub is getting there, transportation, having time to be able to do this intensive outpatient. So this is an option for patients if they're interested. Another option is behavioral health. So Dr. Snyder and Dr. Brayu said most of these patients do have co-occurring mental health issues, and
They may be treating that mental health issue with alcohol.
Yep, so they have no problem. They would love to see the patients. They can't commit to same day or next day like Open Door would just because of their schedules, but they said within a week they would be able to see patients. And they also can do more medical assisted treatment, so they can help with different medications to help someone detox, basically. So if someone is local and can't drive to Ellsworth, doesn't want an intensive inpatient, we have behavioral health as well. You know, they don't have an intensive outpatient treatment like Open Door, but they have what they have, and it's an opportunity. And like you said, different things are different for other people, or different for different people based on their life situation. And then primary care. So you know, trying to get them hooked up with primary care who can try and quarterback what's going on with their lives. If we can get a health recovery coach, we would also include them into this, and it would be ideal to have a health recovery coach that we could call for alcohol and opioid substance abuse, and have them kind of quarterback this process. And I see them as very similar, and we could have the same process for both. Identify and refer. If that makes sense. Identify, treat with medications, initiate treatment, and refer to continuing care. Same process for both. Does that make sense? Does this flow okay?
Yeah, 2 questions.
Sure.
So in the, on the page where it says NDI Hospital alcohol withdrawal guideline.
Withdrawal, so we haven't talked about withdrawal yet.
I'm sorry,
The detox?
no, I was talking about withdrawal.
Okay, I was gonna get to that next.
Okay, no,
Yep.
go ahead and finish it up. But back to the Open Door.
Yep.
I'm curious about the residential program, the outpatient program with Hancock County Jail.
Yeah, I didn't talk to Barbara Royal about that.
Okay,
Yeah.
because that's what
Yeah,
that is.
yeah, I don't know enough about that
Yeah.
program.
Okay. all
They
right.
also have a residential program for, was it for pregnant women, Chris?
Yeah.
That's what this is.
Okay, you said something about Jeff. Yes, they do have a residential program for women that are pregnant. So that's available if so.
I was just curious, the involvement of the jail, so can you be there instead of in the jail, or?
Not that I,
We didn't
I
talk,
think
go into
that's
that.
separate.
Yeah,
That's
Yeah.
a separate
we didn't go
thing.
into that detail.
but if we do
Talk
have
about
any
the house,
patients
we
that
talked.
are pregnant, that's another resource. They'll have housing for them,
Yeah.
so.
Okay, thank you.
Yeah, any other questions on that one? Next page is the withdrawal guidelines. And so what the impetus for this was, you know, we talked about the CEWA issue. So inpatient, and, you know, nursing and hospitalists and ED getting on the same page and having a CEWA score, using a CEWA score. Another issue was some of the hospice providers were saying, hey, you know, we need some guidance on these patients that have really high CEWA scores and are abusive and potentially dangerous to themselves and others. So we wanted to create something for those patients. And A, try and prevent them from getting there, right? And B, what to do if they do get there. And try and create some guidelines around how often are we checking CEWA. So CEWA, kind of keeping CEWA as a vital sign, sort of. You know, it's not a one-time check and done, I did my CEWA. This is like a heart rate or an O2 sat, right? This is something that we're measuring, like an O2 sat, to see if we're getting better or worse.
Which I think on the program upstairs, I think it was every 1 hour or 2 hours that they were supposed to be checking.
Depends on the score.
Yeah.
Right, depending on the score.
Yeah. Yeah. So
Um,
basically, big picture, if you look in the top left, this is where most people are going to be. So, you know, they have so also I'll include RAS. So what is the RAS?
Right.
So Richmond Assessment, Richmond Agitation Severity Score.
That we're supposed to be doing for people that do procedural station.
We're supposed to do it in
For patients that,
Procedural
for definitely for post-intubation, we've been doing the
I
RAS.
think it was on procedural sedation, it's on our,
Okay.
on our policy.
Okay.
Yeah.
So the RAS, so the Richmond Agitation Severity Score. So I should have printed that out too. But both of those are in T-System,
It's
correct?
in system, yeah.
And so we wanted to try and have a CWA and a RAS score. And our goal RAS score is between 0 and 1. Yeah, 0 to -1. And basically means they're calm. 4 is like agitated, freaking out. A -4 is obtunded. If that gives you just kind of a ballpark. And basically, if you're in that top left, this is where most of our patients are going to be. They're going to be, here's some oral Librium, we'll give you some Librium based on your CWA score. If that's not working, here's a dose of diazepam IV. And then hopefully get you back into the oral Librium protocol. So I kind of see this as like a little circle here where most of our patients are going to be. Does that make sense?
Mhm.
A circle around. Then there's going to be patients that, oh boy, that's not working. Okay, so that didn't work, that one dose of IV. So now you get into the big doses of Valium. And so it kind of escalates quickly. Once you get to the right side, you're giving 10 doses of Valium every 5 minutes. And then you're giving big doses, and then 20 milligrams. And then eventually once you have 150 milligrams of Valium,
Wow,
which
and the
is-
patient's still breathing.
patient's still breathing.
Yeah.
Right, because you gotta think these are severe alcoholics who've
Right.
built up so much tolerance. Their GABA receptors are just like, you know, way, way high. So you'd have to give crazy benzos to get those things to even receive any.
Certainly doesn't hurt to monitor them.
Yeah,
No,
right.
no,
So
yeah.
once you start getting this bottom right, then you're thinking, okay, intubation. Right. So this bottom right is the, you know, now we're giving a ton of
So we don't want seizures.
Valium. We're considering, then we switch over to Versed drip, right? And then if that's not working, propofol, you know. So once you're in that Versed drip, you're thinking intubation, and, you know, propofol, definitely they're intubated at that point. So bottom right is, you know, the rare things are not going well. What do I do? So yeah, that's sort of.
Which Mary Lou, we used to see those people, right?
What's that?
People in severe withdrawal, and we
Yeah.
don't see that much of
Yeah,
it.
Yeah, I mean,
I
we'll,
still see him.
I
I don't know
hope-
where you've been working.
I hope that, you know, more of the people that come in will be on this right side already withdrawing, not that they've been with us and get to that point.
Yeah, right.
Like
I think
Overcome
IV alcohol is a
clinic.
wonderful idea.
IV alpha.
I worked in a hospital that still had a protocol in their own little medication book for an alcohol drip.
Yeah.
We used to,
Nice.
yeah.
Now we have fomeprazole.
Why not?
Yeah.
So, yeah. So
Well,
for,
do we have it?
so usually, no, they don't, but yeah, we talked to pharmacy, another story. So yeah, that's a withdrawal guideline. So this is going through med service. This last one still has to kind of go, like, these aren't like approved yet. We're working towards them. So there can be definite changes, and please, if you guys have other opinions, let us know. But I figured it'd be good to kind of talk about.
So now here's the place for my question.
Yes.
About the alcohol withdrawal.
Yes,
And are the Librium doses here the same as upstairs?
this would be
It's
for
gonna be a
the,
standardized.
this would be a standard whole hospital,
Thank
because having
Yeah.
two didn't
Yeah.
make sense. Having two with different scales made even less sense.
you. Right, right,
Yeah,
yeah.
I have
thank
a
you.
question.
sure.
With the Valium shortage, are we
Yep.
not?
So, good question. So, you know, this is a guideline. The best scenario would be to use Valium, but if it's not available, use any benzo. Yeah, so other benzos work as well, but the good thing with Valium is that so Ativan, its metabolites don't do anything. So it peaks and then drops, you know, up and down, where Valium, it breaks down, but its metabolites also are GABA agonist, so it just kind of slowly goes down. As it breaks down, it's still helpful. So that's why it's better. But Ativan lasts for a long time and be fine. It's just over a period of time you start peaking. So you gotta use what benzos you have available, but we figured put what best case scenario is, and if there's a shortage, then adjust. If that makes sense.
Now, on the protocol, so I looked at the one that Kelly did, just because I wanted to take a look at it to make sure it jived with everything, and I think it needs some tweaking, but she's got pause on there. Did she
Oh,
talk to you
so
about
that's
that?
another thing. So I look at that as a separate,
Okay,
I look
she's
at,
got it together.
I know, but I look at it
Okay.
as separate, so I've told you that many times. So the why, I told you why we needed something for that. There's another issue is wanting to identify patients that are at risk for going into withdrawal. Someone comes in for a knee replacement and says, oh yeah, I drink, several. So the pause is a tool to help identify patients who are at risk for going into
Okay.
withdrawal. And so I think valid and needed. I just don't want them to get confused and like, I kind of see them separate, you
We
know?
should talk though.
Yeah, so I mean, I think we get through the thing that's needed first and then add something new later.
Okay.
Just because I don't want to confuse people with,
Okay.
boy, you got RAS and SIWA, because RAS, SIWA, and pause, it just might be too much. Especially with SIWA's new upstairs, so don't want to overwhelm.
Yeah. So, because medical services is on Thursday, I think we
Yeah.
talk about it then, so I want to show you
Yeah.
maybe tomorrow.
Okay. That's because what I saw, it was the first page was pause, but
Yeah, and
she has it
then
intertwined.
they are, it's all in the same document, and then it's missing some text. So I just wanted to show you,
Okay.
yeah.
Yeah. Is it different than what this is?
I didn't compare it, she
Okay.
compared just to the CELA and to the,
Okay. Got it. Yeah, I mean, I think the SIWA is just a standard, right? It's gonna be,
When I was
It's empty
supervisor
system.
on the floor, MedSurg told me that they would rather have CEWA than whatever it was that
oh, good.
they were using.
So it sounds like it would be a welcome change. I mean, like I said, it still has to be approved to go through all the processes and all that other stuff, but.
I don't know how it got changed. They used to use CEWA on the floor.
I don't know with the advent of changing over to evident order sets, I don't know if that's what happened.
Don't know. Before me. Cool, that's all I have.
Well, good.
Any other questions?
Good.
I have a phone call. I need to-
Okay. Thanks, Nathan.
Are you guys still, because are you still?
yep, it's still on.
Oh, watch out, I put this
10 to 3, and then,